Muchas gracias. Thank you, ladies and gentlemen. Thank you, GE and the SERAM for this kind invitation. I'm very honored to be here in Madrid. And I'm very pleased to present you my work from me and my team in Paris about 4D flow imaging, which is, I think, a very promising technique. And I can say it's a kind of very new thing. It's kind of a revolution in cardiac imaging, because I'm convinced it will change the indication of cardiac MR, providing new indication. And also, maybe we can have some minutes or time to discuss with this point. It will be also a new way to perform cardiac MR, because, well, I will try to convince you about that. So, the title is Various Works, 4D Flow Cardiac Imaging from Research to Clinical Application, because there is some papers about 4D flow imaging for maybe 5 or maybe more than 5 years, but we don't see at the present time many clinical applications in routine, and I can show you that it's just coming now. So our experience is based on a GE MR450 W1.5T machine, and we use a 4D flow sequence provided by GE. It's still a research sequence, but very soon, in maybe next month or in 2 months, it will be commercially available. It's a spore gradient echo sequence. It's a gadolinium enhanced sequence, even if now there is some possibilities to do it without gadolinium. But at the present time, we use either a single or double dose of gadolinium, allowing us to provide late gadolinium enhancement just after, so you don't, you can integrate this sequence in your clinical routine without expanding too much the time of acquisition. It's important to note that it's a free breathing sequence, so very easy for the patient, no breath hold, because cardiac imaging with MR is hampered by this many breath hold to make to the patient, and well, sometimes they are ill. It's why they are in the MR. So it's easy to perform for the patient, but also for the technologists, because it's just a volumic acquisition. It's just a box. You just have to know that the heart is in the middle of the thorax. So with this information, you cannot miss. You don't have planes to program, so it's really easy to perform. Now, what is not so easy, and it's probably why it's not so popular at the present time, is the post-processing. And now GE has provided a solution with Arteris, which is an American Californian company, which provides the post-processing on the web. So you have to send your data to the web. It's big files, and after now between 15 and 30 minutes you get back the possibility to treat your image on the web, even at home, even if it's not a good idea sometimes. So it's a cloud-based processing, so it's a new concept. We can discuss of this point maybe later. So 4D flow, before to be 4D flow, it's a 3D imaging technique. So it's also an angiographic image, so it may replace our angio sequence we use for MR, for example, for aorta or for pulmonary vessels. So this is an example of data, and you can recognize anomalous right pulmonary venous return, a scimitar syndrome. And here you can have the streamlines, and you can appreciate the pathway of the shunt from the right pulmonary vein, going to the inferior vena cava, going back to the right chambers, and going back to the right pulmonary artery. So, and you will see, you can measure and quantify all these shunts. With 4D flow, you can see stenosis and regurgitations. In this case, it's self-explaining with the image because it's color-coded. The red color means high velocity flow, and you can see here bioprosthesis, which is with a stenosis and a leakage. So you have both regurgitation and stenotic area. So it's easy to understand, and also you can have the streamlines, and you can detect vortex, for example, in the aorta. And this is a case of aortic coarctation here. And you can appreciate the vorticity and the complexity of the flow, both within the aorta, within the coarctations. And for the moment we don't know, but probably this information will have clinical importance in the future. This is another example of vortex, a double vortex. Here you have, sorry. So go back to the good slide. So you have a vortex in this way due to the regurgitation, aortic regurgitation. And here you see already delayed enhancement. You have a small myocardial infarction, and you are a vortex in the opposite way. So probably this may explain some dyskinesia and may also have clinical importance. Of course, this is in the research field, but you have new information you didn't get before. 4D flow is relevant for post-surgical evaluation. For example, in this case of tetralogy of Fallot, you have the pulmonary artery, and you see clearly the regurgitation of the pulmonary valve. So you can quantify and follow the regurgitation over time, which is mandatory for patients with tetralogy of Fallot. There is complex case where a 4D flow provides you very important and relevant information. In this case, you can see both aortic regurgitation and mitral regurgitation, and you see the dilatation of the left atrium. You see the red color, which means high speed velocity in the mitral regurgitation, and so you can evaluate separately both of this regurgitation, and compared to echocardiography in this complex case, you add very important information. In some situations, echocardiography has some difficulties because of a mitral clip. So you see the double flow incoming in the left ventricle, and this is due to the closure, the partial closure of the mitral valve. So it's a normal finding now, but with echo they are not able, due to this dual flow, to evaluate clearly what is happening, and in this case they were not able to evaluate clearly the mitral regurgitation associated in this situation. So now, and I think the most important point of my talk is to see how this technique will change medical decision, because you can have nice progress in imaging without great impact in clinical management. But I'm convinced that with 4D flow you will have very clear impact on clinical decision, and I will show you relevant examples. So this is it's real life examples. 20-year-old woman with a recent onset of fatigue, tachycardia, and she was sent to MR because of a dilated right ventricle on echocardiography with no defect visible, and so they They went for evaluation. So in 2D, the reality is that shunt is difficult to detect. Maybe you can guess there is a shunt here, but it's not really. If you are not just in the good plane, it's difficult to assess. Now, using 4D flow, because you are in a volumic acquisition, you can scroll over the volume from top to bottom and from bottom to top, and then to stop here, you see clearly the atrial septal defect. You can use the vector to see if the flow is bidirectional or unidirectional. So, and you can also quantify the shunt. So how to quantify the shunt and how relevant are the numbers? So the first way is to delineate a region of interest directly on the shunt. You can, because you are in 4D, you are just perpendicular to the shunt, and you have directly the flow which is crossing across the shunt, and in this case it's 2.3 liters per minute. So now, what is the reality of this number? And by echo they have numbers, but you have to check the numbers. So after you can use the 4D flow to measure pulmonary flow and aortic flow. So the QP is 5.8, the systemic flow is 3.4, so the difference is corresponding to 2.4, which is very close to the direct measure of the shunt. So you have a control of what you are doing, and in this way you are quite sure of the value of the flow. So, and with the experience, I think with 4D flow we have very, very precise flow measurement. There is of course a learning curve, but with 2 months of experience I think you can be very good in estimating blood flow. So here the QP, the ratio QP and QS, it was over 1.5, so it was an indication for closure which was performed, and in this case in particular by echo they were not able to quantify this shunt. This is another case of ventricular septal defect which was seen by echo, but there was it was strange for them because they didn't see dilatation of the right ventricle, and they were not able to quantify this septal defect, the flow. And with 4D flow you are able to understand what was happening. So there is a ventricle defect, the flow is coming in this direction and is hitting the tricuspid valve and going back to the right atrium without penetrating in the right ventricle. So it was a reason why the right ventricle was not dilated, and here we were able, in this patient with pulmonary hypertension, to quantify the QP and QS ratio, and it was an indication of surgical treatment. Another case in a 70-year-old man with a bioprothesis 9 years ago, with a progressive dyspnea. On echo they see aortic regurgitation, but they have a poor acoustic window due to the bioprothesis. And the question from the surgeon is was it a paraprothetic or intraprothetic regurgitation? In the first case, the patient will go to a TAVI, and the second case, it will go to the surgery. You see on the CT scan here the metallic implant, so it was difficult for the echo due to see what was happening. But it's very easy with 4D flow imaging to see that the leakage was clearly intraprothetic. So you have the information which is clear, 100% sure, and you choose the TAVI, the valve-in-valve procedure, instead of surgery because it was intravalvular leakage. Another case of previous coarctation during childhood, a young man came for persistent hypertension, and it was not evaluable by echo because of the position of the coarctation, which is far from isthmus. And on CT scan, it was a 50% stenosis. So was it relevant? The stenotic, was it clinically significant or not? And with 4D flow, we were able to calculate the speed because probably the membrane, there was a high speed in this 50% stenosis, and you can evaluate the gradient of 20 millimeters, which correspond to an indication for re-intervention, at least clinical significance. So we conduct a study about aortic regurgitation with a head-to-head comparison between MR and echocardiography. We select patients with various degree of aortic regurgitation at echo, and the assessment of severity was made by two experienced echocardiographists, each of them with more than 20 years of experience. And by echo, experience is very important. And they have a separate rating and then a consensus in a core lab with a 4-grade scale. Maybe as a radiologist like I am, we are not used to echocardiographic classification, but when you look, the European recommendation to quantify aortic regurgitation, you can be surprised because you have quantitative, semi-quantitative, and qualitative parameters with 10 different parameters to finally classify aortic regurgitation as mild, moderate, or severe. Moderate can be subdivided in two categories, mild to moderate and moderate to severe, so you can achieve 4 categorization. But you have 10 criteria, and sometimes the criteria are not in the same direction. So you have to have experience to decide which criteria will take over the others. So it's a very difficult task, in fact, and you need a lot of experience. And with 4D flow, we decided to just choose one criteria, which is the regurgitation volume in milliliters per bit. Sorry, I go back. And you just have to trace a region of interest on the sinotubular junction, and you have the curves, and the reverse flow is given in liters per minute, so you have just to divide by the number of bits per minute, and you have the volumes, the regurgitation volumes in milliliter per bit. So this is 3 examples, and we decide to use the same numbers as echo classification. So less than 30 milliliters, it's a mild, by MR, it's a mild 1. Mild to moderate between 30 and 45, between 45 and 60 will be classified as moderate to severe, and a severe regurgitation will be regurgitation with more than 60 milliliters per bit on MR. So this is 3 examples. You can see here also, you can have an idea of the mechanism of the regurgitation. Here you have probably a prolapse and with an eccentric regurgitation. And in this case, you can see a huge dilatation of the aortic root with a central jet, so it's a central regurgitation. And you can also have additional information by, for example, tracing a region of interest on descending aorta, and you see here the holodiastolic reversal flow in descending aorta, which is a very good criteria of severity of aortic regurgitation. So this is our statistic, kappa statistic of comparison. So the diagonal line is corresponding to the agreement line between the two techniques. You see that the majority of cases are in agreement, with a tendency of MR to underestimate, in some cases, regurgitation, if you consider that echocardiography is still the reference. But my guess is that in the future, maybe we can change this paradigm and change the concept, and I'm convinced that in the future, MR will be the reference. But it's a personal opinion, and I cannot write it like this in a paper at the present time. So the statistics provide very good agreements with no more one-step difference between MR and a consensus of two experienced echocardiographists, with more than 75% of correctly classified cases, and most importantly, all severe cases were correctly classified. So my conclusion is that 4D flow provides aortic regurgitation evaluation close to a consensus of experienced echocardiographies, and at the time of the study I had only 6 months of experience with 4D flow, and the acquisition is independent from the observer, and it's, as I told you before, it's easy to perform. There is no special skills for the technologist, and moreover, you use just one parameters, the regurgitant volume, to compare to a very complex evaluation by echocardiography. But of course, you have also other parameters like left ventricular volume, which is where the gold standard is clearly the MR. There is no more discussion on this point. Just one slide to stress out important future for 4D flow is the notion of wall shear stress, which is very promising. Here is a young patient with a bicuspid valve. You see the high velocity flow, which is striking the aorta at the point where it's the most dilated. So probably we will see relationships between the blood flow direction and the dilatation of aorta. So maybe we will have new tools to decide when to perform aortic root surgery, not only the size of the aortic root, but also from dynamics information from the flows. So this is not established yet, but it's likely in the future. So my conclusion is that 4D flow is a new technique, but now usable in clinical routine, and in 2 months it will be commercially available, which provides diagnostic and quantification. I see some main fields of interest as valve stenosis, valve regurgitations, aortic flow patterns, the notion of wall shear stress. I think it will be obviously the reference method for all chance and congenital disease evaluation, and you know there is more and more adult congenital heart disease case to follow up over time due to the huge progress of pediatric surgery. Now we are going to follow more and more important population of grown-up congenital heart disease patients, so it will be a lot of patients, and I think there is a lot of interest in patients also with pulmonary hypertension. But if you consider that, for example, in the US, there is 20 million echocardiography performed by year. If you expect 20% of them should go to MR due either to poor acoustic window or inconclusive or maybe surgical decision to take, I think it could be in the range of 4 million of examination to perform in the US. So it's a huge potential which is almost not done by MR at the present time. So if you think of that, it will be a new population of patients, and it's a very, very, very new field. Thank you for your attention.